Thank you very much for the invitation. Thank you, Scientific Committee and the Organizing Committee. Always a pleasure to come to it. Has a special place in my heart. So I was asked today to talk about a ultrasound in neonatal emergencies or emergencies in the NICU. So this topic in my head is just, we're talking about the crashing neonatal protocol. It is something that I really am very passionate about, and I like to talk to all neonatal practitioners about. It is something that in year 2025 now is considered to be a core competency. I have nothing to disclose. So my objectives for this talk is to talk about the recommendations about ultrasound guided resuscitation, also to talk about the applications for this assessment. I'm going to focus on two major applications, which is cardiac and lung, and we're going to go through a few examples. Also, we're going to do a couple of scenarios, and then we're going to talk about the future direction. So I'm sure many of us in the NICU care providers, we're having a baby that is not really quite sick or could be sick, and then we suddenly have the complete deterioration of the vital signs. We know from our training in residency, fellowship and such, we should start with ABC, starting with the airway, breathing, circulation, and try to stabilize the patient. But what part of that stabilization is about further evaluation and finding out what is really the cause of that deterioration. If we are going to just do chest compressions and intubate all babies and go through the steps of NRP in resuscitation, are we really finding out what is going on during that decompensation? Is there a reason of something reversible or not? Now, once people start learning how to use ultrasound and use echo, you can see that you can't just leave it. If you know how to use the machine, you're going to find out that you're going to walk with it during rounds. And this is where those group of experts sat down and wrote those recommendations. It is the crashing neonatal protocol. It is a protocol for systemic assessment of the crashing neonate. You got people from North America, you got Canada, and you got from Europe. So the main applications for the main domain is to look at the lung ultrasound, which is to rule out major pathologies, including pneumothorax, looking at cardiac ultrasound, because the intervention in each decompensation is very different. And if you move into a certain pathway, you're actually missing out the original problem. And then you have abdominal ultrasound and cranial ultrasound that I think they are important, but may not be as important as lung and cardiac. And I gave this talk a few years back, and I had this slide only. And there was a discussion at that time that not only during initial crashing or decompensation and abnormal vital signs we're doing the assessment, now they're moving more into assessment during cardiac arrest. And it's no longer something in the future. This has been published 2 weeks back. So Yogan Singh, who was just a genius working in California, he wrote this new sonar, which is neonatal sonography assisted resuscitation. So you're checking your heart rate, you're checking for the secondary factors that causes the cardiac arrest in those patients, and you're incorporating it into your NRP and your chest compressions, epinephrine, everything, and they focused really on not disrupting the workflow. And you can see here, they did it a few times actually on simulation and on animal models. And they're using it in clinical practice right now in that institution. And they really are not the pioneers in this. This is already well known in the adult world, especially adult ER and adult intensive care. I think things start from adult and just move gradually into pediatrics, and I think neonatology is probably the last field that adopt those things. So general indications for the crashing neonatal protocol obviously is during resuscitation. The patient you're doing your initial steps, you're checking that the equipment is correct, the tube is in place, and the baby is not responding. Or in cases of shock, you can see that there's a deterioration of either heart rate, blood pressure, systemic perfusion. You have unexplained lactic acidosis, which is really the last sign you should see in the poor systemic perfusion, or worsening hypoxia, or a sudden hemoglobin drop. And again, we're not really expecting everyone to become an echocardiologist or become an echo technician, or become an ultrasound technician. You see on this pyramid on the top here, there's echo. That's something done by the pediatric cardiologist that requires extensive training. And then you've got the level beneath it, which is the targeted neonatal echo and hemodynamic assessment. This is something a neonatologist, an intensive care physician, pediatric or adult, can do a training for a year, sometimes even less than that in some countries, and they get competencies in functional assessment of the heart. And then finally, you can see at the bottom of this pyramid is point-of-care ultrasound, which is a core competency now for all practitioners. And it doesn't really require extensive training in comparison to other ones. And as I mentioned earlier, NICU is a bit behind in comparison to the PICU. And the skill is somewhere between a cardiologist, a intensivist, and an imaging specialist. Now, talking about cardiac focus, which I think is very important. The yes or no answer is just for 4 different questions when you're doing cardiac focus. Is the contractility fine or not? Do you have sudden poor contractility? Do you have a tamponade? Is there a PICC line or a UVC that is extravasation? Is there an empty heart? Is the baby in a low systemic vascular state for a long period of time, went into third spacing, and the heart is completely empty right now? Or you have evidence of pulmonary hypertension, which pulmonary hypertension, if it's very progressive, it's going to affect your preload on the left side of the heart. Now, without going into the technical part, which hopefully we'll be covering in the afternoon workshop session that I invite you to, as all of the fellows that come for us for a rotation of the point-of-care ultrasound and hemodynamic assessment, we focus on the apical 4-chamber only. That single view that requires probably a day or 2 of training will give you your forehand questions that you want. You want to see in the heart in an anatomically correct position. You want to see the left atrium, right atrium, left ventricle, and the right ventricle in their correct position. The apical 4-chamber view sorry. So you want to go through it and ask yourself a specific set of questions in each view. So for example, here in the apical 4-chamber, you want to assess the contractility of both of the ventricles. You want to assess the size of the ventricles. You want to see if the RV is bigger than the LV, and that's definitely abnormal in those babies. You want to look at the left ventricle. Is it small, underfilled? It kind of gives you like a hypertrophied look, although it's not. It's just because it's empty. And you want to look at the position of your septum, if it's being pushed in a certain location. And also you can do color interrogation, color Doppler on both sides. Now, without being an expert in echocardiography, if we just put this image and I tell you just compare the right side and the left side, do you see any abnormality? I think most of us cannot really appreciate it. You can see on the right side here, there is poor contractility. The fractional area change in the left ventricle is not changing much. You can see the valves are barely opening and closing. But in the normal one on the right side, left side here, you can see the contractility just by qualitative assessment and eyeballing is good. So that definitely will change our management. Rather than just giving a bolus in that baby, we need to support the left ventricle by giving an inotrope, like dobutamine or epinephrine. But for example, if we had a baby that's decompensating, having hypotension, and is basically in a shock state, and you look at this one, what you can see on the left side here, the left ventricle is very small, looks very gray, it's underfilled. That's a very important sign of a low preload. So this baby is going to be treated differently. You need to give more volume, and then you give a vasopressor rather than an inotrope. But for this one, for example, you can see very clearly that the right side here is bigger than the left side. So this is a clear sign of pulmonary hypertension. Now, we're not asking the general neonatologist to diagnose pulmonary hypertension, but at least to suspect it in the clinical context, and then start treatment based on that. Now, always ask for help. Same thing, you can do it with the color Doppler on the right. Parasternal long axis, you can ask the same set of questions. Same thing you can see here. If you're doing parasternal long axis, you're seeing poor contractility on the right side here and very normal contractility on the other one. You will definitely change your management. Here, for example, you have an effusion. You can see clearly that there is an area under the left atrium here where the fluids are being accumulated. That's the sign of pericardial effusion. We had a baby recently. Actually had a sudden desat, sudden drop of blood pressure, and also the heart rate started to drop down. It was done by a fellow actually. A quick assessment of the heart shows actually the heart is dancing in fluids, and that's TPN. Pericardiocentesis revealed that there is TPN around the heart, and it was evacuated and the baby got better. Another very important indication, which I think from all indications of point-of-care ultrasound, this is probably the easiest and the one that can be really learned from a workshop. And I safely can say that if you learn this in a workshop and you have a mentor for long-term assessment, you're able to diagnose or pick up at least the major pathologies, including pneumothorax. So for lung focus, you have pneumothorax and consolidation and effusions. And this is really not something new. Starting from the beginning of the 2000s, we see the international evidence-based recommendations that's been out, and you can see also international expert consensus, and also the European Society, the ESPNIC, published this a long time ago, and there is pretty much good agreement. And recently now in 2022, in the US, the American Academy of Pediatrics published a couple of reports, a technical report, and also a statement of how to use the point-of-care ultrasound in neonatology. And this is a common question that I get, that are we really going to do this? Who's going to protect me? I am not well trained. What if I am trained but something goes wrong? Am I going to be blamed? Should I just stick to the old X-ray? I'm safer that way. Now, you'd be surprised now in the US, the lawsuits are actually now asking why ultrasound was not used in the assessment as such and such, especially for line extravasation, for rapid assessment of a pneumothorax. Was there a delay in management? Maybe we're still behind in Saudi Arabia in terms of that legal part, but I assure you within 5 to 10 years that question will be raised. Pattern recognition is also easy to appreciate. Just asking a couple of questions. Is there A lines present, and is there B lines present? Are they coalescent or not? And if the B lines are separated or not? So A lines, I remember it like air lines. If the lung is well aerated, you're going to see the air lines. I'm going to show you in a bit. And B lines are bad lines that go from up all the way down. And if they are separated, you can see them clearly separated, and if they are coalescent, it's one big white lung. This is what we see. 5 minutes? Okay. This is what we see really. If we're doing using a linear probe and we're seeing those, those are the ribs, and that's the pleura down here. We can see lines that go all the way from up down here. Those are the B lines that indicate fluids. You can see multiple B lines here as well. But on the other hand, those lines that are horizontal, that indicate good aeration, are called A lines. And that's to be covered also in the workshop. Okay. You really don't need to do a full lung ultrasound when a patient is decompensating. You don't need to go through the zones. You don't need to know the full way to report it. You need to hold the machine and sweep the lung from up till down, and just ask yourself, am I seeing B lines? Presence of a single B line actually rules a pneumothorax, and this also has been published multiple times. This interesting study looks that if you see a single B line in lung ultrasound, that rules out a pneumothorax. And if you don't see it, then that raises a suspicion. The sensitivity is around 100%. Now, you can see here, for example, we're seeing, it's a static image, but you can see on the right side, it's a bit grainy. So that's called the seashore sign. And on the left side here is the pneumothorax, where there's no movement of the pleural line, and that's a barcode sign. Take this one, for example. This is a patient that we had, was on high frequency, had lung hypoplasia, suddenly started to decompensate. Not that they started well, but they started to decompensate even further. You can see here the lung ultrasound clearly shows that there's not a single B line. It's all complete A lines, and there's no sliding, and that's a sign of pneumothorax. smaller ones, actually you can appreciate it even more with a lung ultrasound in comparison to the X-ray. I'm sure all of us, we've seen X-rays before, and we had an argument with our colleagues, is this a pneumothorax or not? Now, with lung ultrasound, even tiny ones you can see it, and you can see here clearly on the right side of the image, there is the B lines, the lines that go all the way from up to down, and on the left side you don't see any of that. That area of transition is called the lung point, and that's really pathognomonic for a pneumothorax. This is a patient that we had that's had also sudden decompensation, and just putting the ultrasound on, we can on the lungs, and we can see here that we no longer see any A lines or B lines. We kind of see a liver-like structure of the lungs. And lung ultrasound is all about artifacts. We shouldn't be seeing structures that are really parenchymal in the way they look. You can see here there are terminal bronchioles. So this means that there is absence of air completely in the lung. And that happens with a complete collapse. Now, an X-ray after that showed that there was a complete collapse in one of the sides of the lungs. And clinically, the baby didn't show it, probably because we picked it up early on. This is how a pleural effusion would look like. It's also pretty much sometimes a bit challenging to diagnose it with a chest X-ray, but we're using a lung ultrasound. You can clearly see a black part on the lower parts of the lung. Now, abdominal ultrasound, and I think those are one of the indications that are a little bit more challenging in comparison to other indications. But what is easy to do in abdominal ultrasound is just to assess for free fluid and also to assess for any bleeding. Now, I don't think I have time to discuss the findings of necrotizing enterocolitis here, but just to summarize, the signs of necrotizing enterocolitis here is much more extensive than what we see on chest X-ray or abdominal X-ray. It's around 12 signs that are dynamic and also by color. And by doing abdominal X-rays, we were not able to appreciate any of those. Procedural. How many of us had a baby with a pericardial, or abdominal fluids that requires training for hydro, for example? And how many of us just went blindly? How are we not assessing if we are going to puncture intestines or not? So you can use it for procedural as well. Assessing really the best point to go in. We have been classically taught that you go to the right lower quadrant and just go in there. Now this baby, unfortunately, by looking at the left lower quadrant, there was intestines there. So we went exactly to the opposite side. That's the danger of using the landmark procedures in 2025 right now, and you have another way safely to do any other procedure. So I won't be going through the algorithm. You can, just have a look at it and assess it yourself. But just a way of thinking about how to go the crashing neonatal protocol is to rule out the major stuff, the easy stuff that we can assess in the beginning, which is lung ultrasound. You rule out the presence of a pneumothorax, and after that you look for any effusions, and then you go down to the different organ, which is the heart. You check for poor contractility, empty heart, and tamponade. And finally is the one that is least effective or the least decision changing is to do the cranial ultrasound and the abdominal focus. Do I have time for a scenario with that? 2 minutes? Okay. So let's take the scenario, for example. A 27-weeker, day 14 of life. This baby was on CPAP, doing well, FI to 30%, started to have mottled skin, increased oxygen requirement, and the urine output started to drop. And before that, actually, the urine output was fine. Blood pressure also at that time is 46/15 with a mean of 25, and we're going to use gestational age for the blood pressure here. This is a 2-week-old, so 29 is the minimum, so definitely below. And the blood pressure previously before that was fine, a mean of 32. So what are we going to do? Are we just going to do our conventional approach by giving fluids, dopamine, dobutamine, epinephrine, norepinephrine, and hydrocortisone along the way? Or we're really going to find out the pathology here? If we're going to use centiles for this baby, for a 29-weeker, the mean is around 27. And what's really affected in the blood pressure components here is the diastolic blood pressure. So that really reflects your preload more. So after doing the point of care ultrasound for this baby, we can see here that the left ventricle is really small. It is underfilled, low preload. And also assessment of the LV output, increased LV output. So your systemic vascular resistance is low. And also you have other signs which I won't go through right now. But just going back to science here, and the formula, which is the mean arterial pressure equals the cardiac output multiplied by systemic vascular resistance. You have an empty heart, no preload, and the SVR is really low. This means that your cardiac output is really high, therefore you're dealing with the low systemic vascular resistance, says a warm shock physiology. And that management here is preload optimization, vasopressors, and like norepinephrine or vasopressor. I don't think I have enough time for this one, but just to summarize it, this is a baby that was just finished handover, one of the consultants, and the baby was admitted a few hours ago. They finished putting line, everything was fine. Suddenly the blood pressure dropped. Doing the echo was difficult in that baby. We were not able to see anything, so that raised the question of why am I not seeing anything? Lung ultrasound done at the same time shows the pneumothorax. Now you can argue that doing an X-ray also could have helped in this situation. But X-ray was just done prior to that, so sometimes convincing the team that we need to repeat something, you can get a lot of resistance. So, future point of care ultrasound, using AI. AI is no longer the future, it is already there. When I presented this was not available. So you can do strain assessment, you can do auto-ejection fraction, you can do bladder volume with machines that are available now in Saudi Arabia. For example, this is an interesting one, that where you can do just an apical 4-chamber learned by a fellow, and they can estimate the ejection fraction of the heart, and you get a number on the screen. Training is available. Unfortunately, we don't have a structured program right now, apart from the POCUS that we're running twice a year in Saudi Arabia in collaboration with POCUS in Canada. But there are so many workshops around there. We're doing boot camps for hospitals as well. And you need somebody in your hospital to be your mentor, probably a cardiologist that can help you. So take home messages, and I'm finishing. So use of point of care of ultrasound is here to stay. It's not going to go away, so you better accept it. And it's very useful in rapid decision making in the patient that is decompensation. Think of it as an extension of your clinical exam. It's a stethoscope with a monitor. And also appreciate its limitation and ask for help if you're not sure. Thank you very much.